Hello viewers, welcome to my channel Gynae and Obstetrics by Dr. Gupta. Me, Dr. Sanjay Prasad Gupta, a gynecologist. Today's topic of discussion is thyroid disease and pregnancy. Thyroid hormone is secreted from the thyroid gland which is situated over the neck. Now, thyroid hormone is required for all the normal cellular function, development, steroidogenesis, metabolism and specific tissue activities. Now, during pregnancy what happens? The requirement of thyroid hormone increases. The reason is increased secretion of thyroid binding globulin because of the estrogen effect. Stimulatory effect of HCG over the thyroid receptors, TSH receptors. Increased metabolism of thyroid hormone because of increased deiodinase activity. There is increased requirement of iodine also, which may be deficient in the diet, that also cause increased secretion of thyroid hormone. There is shunting of thyroid hormone from the maternal blood to the fetus through the placenta, and there is at the same time increased excretion of the thyroid hormone also through the kidney because of the hyperrenal perfusion. So all this needs increased requirement of thyroid hormone. So if there is increased requirement of thyroid hormone, so we need extra iodine also to be supplemented if it is deficient in the diet. Especially iodide salt or fortified iodide salt is recommended during pregnancy and all the time to avoid thyroid dysfunction. But if there is in the deficient area, we can give some multivitamin tablets containing 150 microgram of iodine in the vitamin each day, which may fulfill the increased requirement of the iodine in the pregnancy. Now what happens to the fetus? Fetus is there is till 10 to 12 weeks, fetus can secrete its own thyroid hormone, but to get it fully functional, it needs TSH also, which only secreted in its full form after fetal hypothalamus gets functional, which occurs at around 18 to 20 weeks. So in the first 20 weeks of intrauterine life, the fetus is totally dependent upon the maternal thyroid. So even if the mild form of hypothyroidism, it has been seen there is deficient neurocognitive or neuropsychiatric development in the fetus, which results in abnormal IQ or intelligence in the infants and in the childhood. So even in the mild form of hypothyroidism, it needs treatment with the thyroid hormone. Now, how to diagnose thyroid disease in pregnancy? If it is apparent from the signs and symptoms, which is obvious, then we can diagnose easily. But mainly the subclinical types of hypothyroidism, there is may not be any signs and symptoms. So the specific marker is TSH. TSH has to be tested, which is a very sensitive marker for thyroid dysfunction. Now during the pregnancy, what happens? The normal level of TSH level decreases because of increased thyroid hormone in the blood. So the normal value has to be decreased in the pregnancy. American Thyroid Association, that is why, has recommended trimester wise specific values for the TSH during pregnancy. First trimester it is 2.5 and less, and in the second and third trimester it is 3 and less. But it cautions that it has to be modified regarding the area, ethnicity and region of the population where it has to be considered for TSH testing. Now when the lower limit is not available for the considered population, then 4 and less can be considered. So in Indian subcontinent, we can use 4 and less as the TSH normal, upper limit of normal during pregnancy. Now how to interpret? When the TSH is below 4 than less than equal to 4, then we call it in the normal range. When it is 4 to 10 and free T4 is normal, then we call it subclinical hypothyroidism. When the TSH value is above 10 and even if the FT4 is normal, we call it overt hypothyroidism. And when the value of TSH is more than 4 and FT4 is decreased, then we call it overt hypothyroidism. Now regarding hyperthyroidism, the interpretation is when the TSH value is below 0.1 and FT4 is in the normal range, then we call it subclinical hyperthyroidism. And when the TSH value is below 0.1 and FT4 is above normal range, then we call it overt hyperthyroidism. Now, in pregnancy, regarding the TSH value, the upper limit of normal is 4 or less. But in some exceptional cases, it can be considered even the 2.5. Now, what are those cases? One is if there is a patient already taking thyroid hormone from before conception. Next, if there is history of subfertility or recurrent pregnancy loss or preterm labor, or if the mother is being considered for ATA treatment or artificial reproductive therapy. Now, next is if the mother is TPO antibody positive. So, in all these cases, the upper limit can be considered as 2.5. Otherwise, in other cases, the upper limit should be 4 or less. Now, the ETA recommends TSH screening of pregnant mother or preconceptually only in the high risk categories. So, what are those high risk categories? First of all, if the mother is more than 30-year-old, if the mother is obese, if the mother is having history of thyroid, personal history of or family history of thyroid dysfunction, if there is history of head and neck irradiation, if there is history of thyroid surgery or thyroid radioiodine ablation, if there is history of sub-infertility, if there is history of recurrent miscarriage or preterm labor, if the mother is in the iodine deficient zone, or if the mother is taking amiodarone or lithium therapy. So, in all these high risk categories, mother needs to be tested for TSH screening during or preconceptually in the pregnancy. So, if we consider all these categories, India comes under the high risk category and there is universal screening for the mothers who is going to be pregnant or pregnant mother as early as possible in Indian subcontinent. All has to be tested for TSH and the upper reference limit is 4 micro international unit per ml. Now, what are the complications of hypothyroidism if it is not treated during pregnancy? There is chances of gestational hypertension, there is chances of gestational diabetes mellitus, there is chances of preeclampsia, miscarriage, preterm delivery, low birth weight, increased chances of intrauterine growth retardation, reduced neuropsychiatric and neurocognitive development, lower IQ in the childhood. So, these are all the complications even in the subclinical or overt form of hypothyroidism. So, it needs to be treated. How does we treat? We should treat with levothyroxine, and levothyroxine dose is to be adjusted as per the value of the TSH, weight of the mother and the age of the mother. Usually if the TSH value is in the 4 to 10, then we start with lower values, that is 25 to 50 microgram. Now, if it is above 10 but less than 20, then we can start with 50 to 70 microgram, and if it is above 20, then we can go with a higher value such as 75 to 100, and every 6 to 12 weeks it needs to be titrated, and after it normalizes, then each trimester we should test once the TSH value, and accordingly we should titrate the levothyroxine drug. Now, what about after delivery? After delivery also, especially if the mother is TPO positive, then there is chances of subacute thyroiditis. In that case, what happens? There is increased thyroid hormone initially, and after that it goes into the normal and then hypothyroidism phase, and after some time it become the mother become normal also, that is euthyroid state. So we need to follow up with the TSH value at 6 to 12 weeks, 6 to 12 months, and even after that if required. And at the same time, if the mother is already taking thyroid hormone preconceptually, then after the delivery, the dose of the thyroid hormone should be same as that of the preconception period. But if the thyroid hormone is started during pregnancy, then if the dose of the thyroid hormone is in the lower range, that is 25 to 50, then we can stop the thyroid hormone. And if it is in the higher side, that is above 50, then she can continue with the same dose even after the delivery, but the follow-up has to be done at 6 to 12 weeks, then 6 to 12 months, and if required further, and accordingly the dose of the thyroid hormone has to be adjusted. Now, what cases we need TPO antibody testing? This is also we can consider if there is risk of preterm delivery or history of preterm delivery or recurrent miscarriage, or there is autoimmune disease in the family, or there is personal history such as type 1 diabetes mellitus, myasthenia gravis, adrenal insufficiency, or if there is history of other autoimmune diseases such as vitiligo, then we should go for the TPO testing. Now, regarding few lines regarding hyperthyroidism. Subclinical hyperthyroidism does not need treatment during pregnancy, and even if some cases it has been seen that, especially in case of hyperemesis gravidarum, molar pregnancy or teen pregnancy, the mother goes into transient hyperthyroidism as well. That is, the value of TSH is less than 0.1 and the FT4 also is in the higher range of normal. So we can call it overt hyperthyroidism, but it does not warrant treatment and it needs only follow-up, especially in cases of hyperemesis gravidarum, and mostly after 15 to 20 weeks the value of the TSH normalizes. And now, regarding the overt hyperthyroidism, it needs treatment, and the first trimester the drug of choice is propylthiouracil. At least has been seen that increased chance of congenital defect if you go for the carbimazole or methimazole, but in the second and third trimester the drug of choice is carbimazole or methimazole. So we have to need switching over from propylthiouracil to carbimazole or methimazole, as ease of the treatment with the carbimazole, it does not require divided doses, and there is increased chance of fatal liver toxicity if we continue with propylthiouracil. So that's all for today. Thanks for watching.